subtitle of our project is Improving Patient Outcomes in Neurological Disorders, and we thought we'd like to pilot a neurogenetic service for refractory epilepsy patients. So our vision was to actually create a Queensland genomic service for neurological patients in the hope to improve diagnosis and treatment of neurological disorders throughout Queensland. Our current goal for this implementation project is to demonstrate that this model of care in refractory epilepsy patients is going to significantly improve their health care in terms of patient quality of life as well as cost effectiveness. So this is the team. For this project, we have 3 sites, a statewide service across Queensland, the Royal Brisbane, where there's 7 neurologists, which is a combination of adult and paediatric neurologists, Queensland Children's Hospital, another 7 paediatric neurologists, and then Ian Wilson Upper Cairns-based hospital. And I think the benefits is that we've got this diversity of health services and demographics involving both children and adults, and a wealth of experience among all the clinicians. So what is the problem? Well, neurological disorders represent 7% of the burden of disease. Now, we chose refractory epilepsy because 1 in 26 people will develop epilepsy. And of that, 25% are in fact refractory, meaning they don't respond to at least 2 anti-epileptic medications. Now, we know with epilepsy, controlling seizures is critical to reduce the burden of disease. And so, in fact, the refractory group have poor quality of life due to the number of seizures and the increased frequency of seizures, and as a consequence are a high user of health service with recurrent admissions to hospital, recurrent emergency department visits, and frequent outpatient visits. So what's our solution? Well, the way we first wanted to tackle this is the neurologists are all very keen to incorporate genomics into their clinical care. But often the many questions that I've often been asked by clinicians is, what do we order? How do we order it? Where do we send it? What do the results mean? So the aim of this project is to create a diagnostic and management algorithm for the neurologists to sort of get an idea in a simplistic way of what they need to do if that's the path they'd like to take. Another innovation of our project is to integrate a genetic counsellor into mainstream services. We'll have a genetic counsellor working in neurology whose aim is really to consent the patients, educate both the clinicians and the patients, and provide the ongoing patient support. One of the things many of us know in a busy clinic, it's very hard to take the time out to sit and discuss and properly provide informed consent. Then the genetic counsellor, who will be central to this project, will be part of organising a weekly multidisciplinary meeting. And we felt this is critical for our project because we'll integrate a paediatric neurologist, an adult neurologist, clinical geneticist, as well as a genetic pathologist who will all aim to meet weekly and then establish an idea of the report. Because one of the cruxes I think of this is, and I think Patrick mentioned this, is to create that clinically meaningful report. I mean, I use the report as an analogy, as a neurologist, as an EEG. When we report electroencephalograms, we'll have about a page of, the alpha rhythm, the beta rhythm, which means nothing to someone on the other side. We want something that the clinician can then have a look at, a paragraph at the end that succinctly tries to tie it in of how they can impart this information to their patient and how it can alter their management. The other idea we plan to implement is a patient report. Once again, we plan to write a report to the patient, of which then it'll incorporate means of support from our genetic counsellor, and then the patient too has knowledge and understanding to help their epilepsy journey. And finally, the benefit of all this is to really streamline our referrals in the future to Genetic Health Queensland to ensure that we refer the cases that have complex genetic histories that really need their services. So the benefits and outcomes. Well, the most important thing is to improve quality of life and also in a more efficient health services manner. So the important things for us as clinicians is closure for the patients, years of trying to understand what is the cause of my epilepsy. And the consequence of that is being able to reduce investigations and also, more importantly, looking towards more precision-based treatment approaches, trying to focus our treatment with decisions that may change the clinician's choice of which drug based on their genomic results. Other important ways to improve the efficiency of health services, I was mentioned the streamlined referrals to Genetic Health Queensland, the critical importance of education of the neurologists and changing that paradigm shift where they want to incorporate genomics, but because of the lack of knowledge and not sure how to do the process, to try and make it part of their daily practice. So what's our patient cohort? Well, we know about 94,000 patients in Queensland suffer epilepsy. Between the three sites, there's around 649 patients we estimated from last year were seen. 25% of them are refractory, so you can establish about 162 we were seeing last year. So our sample size we're hoping for is 100 patients, failure of 2 anti-epileptic medications to control seizures. They can have other associated disorders such as intellectual impairment, autism, aged 5 and above, and at this point in time no cause has been established. Now, how we'll plan to undertake this project is these patients are routinely coming to our clinics. So via the algorithm they'll be identified, then they'll be provided with informed consent. And at the time of collection, we'll try and hopefully obtain trio DNA sampling from both the parents and the proband. Results will be generated, and then the weekly multidisciplinary meeting held, of which the 2 reports will be generated. Now, there'll be questionnaires to evaluate the process with a patient quality of life questionnaire, which involves not only quality of life, but their journey and their experiences, which will be done at 6 months after the results have been obtained, and there'll also have been one done at baseline. We'll also incorporate a neurologist decision-making profile. And this is more to try and understand the health economics. And whilst we haven't got a lot of time over the 6 months, it's more to extrapolate what changes will they incorporate in their management based on the results. And once again, that will be done 6 months after the results are provided to the patient.